Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the induction of labor for delivery. Labor may be initiated prematurely at or near the term or after. If it is premature labor, it is called induction of premature labor. If it is post maturity, it is called induction of labor. Induction indications for induction: toxemia of pregnancy, pre-eclamptic toxemia to save the mother and the viable fetus. Antepartum hemorrhage like premature separation of placenta as a method of management of antepartum hemorrhage. Placenta previa type 1 and 2 to control bleeding. Hydramnios. In hydramnios with acute symptoms, in chronic hydramnios, rest and diuretics are given as a trial before going to induction. Habitual intrauterine death of fetus. Some patients give a history of repeated intrauterine death of the fetus around the term without any known reason. In this condition, the induction before the usual term of intrauterine death is a useful procedure. Exclusive size of the fetus. Excessive size of the fetus. In some women with each pregnancy, the babies increase in size and weight, giving rise to an increasing degree of dystocia. To prevent such dystocias due to the excessive size, labor could be induced earlier before attaining the large size. RH compatibility. In RH negative women who harbor an RH positive fetus, the titer of the agglutinin in the maternal blood should be periodically estimated during pregnancy. A rising titer is a guide, and in selected cases, induction of premature labor when the child is viable has been recommended as a means of shortening the exposure of the infant to maternal antibodies. Diabetes in pregnancy. There is a general rule that when diabetes complicates pregnancy, it is advisable to terminate pregnancy a few weeks before the term. This will help to avoid intrauterine death and dystocia due to large size of the child. Many prefer cesarean section, but experience reveals a satisfactory response to induction. If fails, the cesarean section may be employed. Fetal monstrosities. When the malformations of the fetus like hydrocephalus, anencephalus and achondroplasia and monsters are diagnosed by radiography antepartum, it is best to induce labor. Intrauterine death of fetus. In most cases, spontaneous expulsion of a dead fetus occurs within 3 to 5 weeks of intrauterine death. Sometimes it is retained for longer periods, leading to coagulation failure by production of fibrinogenopenia in the mothers. It may also get infected and give rise to clinical manifestations of toxic abortion. Certain patients are afraid of effects of carrying a dead fetus in utero and ask for help in emptying the uterus. Induction of labor at term. There are some indications for induction at term. So, elective induction of labor has found a place. Elective induction means induction of labor at full term in persons who are completely normal and in whom the induction is undertaken as a matter of coincidence. The condition to be satisfied for induction, or the fetus is mature and the surgeon is certain that the fetus is at term. The cervix is soft and effaced, indicating quick response to induction. Presenting part must be vertex, and if the head is not engaged, it should at least be dipping well into the pelvis. There should be no abnormalities of any kind that might make labor difficult. When labor is induced at term in such patients, the perinatal mortality, maternal mortality and morbidity are in no way greater than in the group with spontaneous onset of labor. The greatest advantages is that the patient can be brought into hospital for confinement by appointment, labor induced and delivery conducted as a planned procedure. Post maturity. When pregnancy has gone beyond term, labor should be induced. This is the main indication for induction of labor. Again, it is necessary to be convinced of the maturity of the fetus. We do not induce labor till the patient has gone beyond her expected date by at least 10 to 14 days. Methods. There may be many types, of which only two important types are discussed now: the oxytocin drip and surgical induction, that is amniotomy. Oxytocin drip. Oxytocin drip is based on the assumption that oxytocin is the hormone of nature to initiate labor and affect delivery. A commonly employed procedure was to give 3 to 5 units intramuscularly every half an hour till 10 to 15 units were given, or till labor was established. But the disadvantage is that there is no control over the action of the uterus once the injection is given. It results in intrauterine death of the fetus or the rupture of the uterus. Physiological drip. Oxytocin is administered intravenously so that the obstetrician could be able to control the action completely. The doctor can stop or enhance the contractions at will and adjust the rate of the drip in such a way that almost normal physiological contractions of labor are produced. For safety, the uterine contractions can be recorded by means of a tokogram or tokodynamometer, and of late fetal cardiophenogram has added greater safety by the accurate recording of the fetal heart during the time the drip is flowing. Pitocin was employed at the start. A synthetic syntocinon, equally potent unit for unit and much cheaper, is available. Oxytocin sensitivity test. This test helps in assessing the irritability of the uterus. Increasing the uterine irritability results in labor. The amount of oxytocin required by a patient to noticeably increase the uterine activity forms a method of assessing irritability and has useful clinical applications. Procedure. The patient is in bed and at rest. If a tachograph is available, it could at a great benefit employed to record the contractions. If not available, one has to depend upon the clinical impression as obtained by keeping the hand over the uterus. Oxytocin at 0.01 units per ml is prepared in 10 ml of syringe, and the injection commenced at the end of the spontaneous contraction. The 0.01 unit is injected intravenously at minute intervals till contraction occurs. The total dose given to this point is called the oxytocin sensitivity. The Intensity of the contraction elicited can be noted and is often found to be much stronger than the spontaneous contraction which preceded the test. It has been found that patients on the verge of labor respond strongly but safely to dose of 0.01 units oxytocin, while other patients will require doses up to zero point 0.1 units. The measurement is therefore made between these units. The patient sensitive to 0.04 units oxytocin or less is suitable for surgical induction, that is, they are likely to go into labor within 24 hours after induction. Those require more than 0.04 units to produce a contraction should be treated first with an oxytocin infusion and the amniotomy postponed till the uterus becomes more sensitive. Induction by oxytocin drip. Before the start of induction, the bowels are cleared by a large soap and water enema. Various dilutions of oxytocin have been employed. 2.5 units of syntocinon in 500 ml of 5% dextrose, that is a dilution of 1 in 2000. The drip is first run in slowly at the rate of 10 drops a minute. The rate of the drip is gradually increased till normal uterine contractions lasting half to 1 second at intervals of 1 to 2 minutes are produced and maintained. The medical officer stays with the patient watching the contractions, adjusting the rate of the drip and recording the fetal heart every half an hour. If possible, electronic monitoring should be adopted. If it becomes irregular or very slow, the drip should be stopped immediately. After a short interval, the drip may be restarted and the fetal heart carefully observed. If it again becomes irregular, the drip is stopped and this method is given up. In some patients, the rate of the drip may go in up to 100 drops a minute and still no contractions may occur. In successful cases, the labor is established by the time the 500 ml is over. In some, a second and third drip may be necessary. Not more than 10 units are given in the drip during 24 hours. If labor is not established, considered a failure. It is attempted again a day or two later, or if the induction is urgent, resorted to other methods. Oxytocin drip is usually successful when the head is engaged and the cervix is effaced. Where the cervix is closed and long and the head is not engaged, it is not successful. But it helps to soften the cervix and helps it effacement so that amniotomy can be safely performed. Some prefer to stretch the cervix to admit one finger, stripping and separating the membranes all around the internal os and then starting the oxytocin drip. These procedures are all useful, but much depends upon the urgency of the indication. It is to be recommended that oxytocin drip is most effective after amniotomy. Surgical induction. The method employed is amniotomy or artificial rupture of membranes. As a result of the rupture of the membranes resulting in removal of the most of the liquor amnion, the presenting part, usually the vertex, comes into intimate contact with the lower uterine segment and the cervix, resulting in the stimulation of the nerve plexus and ganglia situated in that region, which provoke the uterine contraction. Amniotomy can be done below the level of the presenting part, then it is termed low rupture, and if it is above the presenting part, called high rupture. Latent period. After amniotomy, there is a variable interval before the labor starts. The latent period is influenced by the factors Level of vertex. If the head is engaged and latent period is much shorter, with a floating head, the latent period is much longer. The nature of the cervix. A thin effaced cervix with external os admitting a finger will respond to induction most satisfactorily. The latent period is very short in these cases. If the cervix is long, effaced and closed, response to induction is delayed and the latent period considerably longer. A soft gapping cervix, though not effaced, has a better prognosis and shorter latent period than the one which is closed and long. When the external os is near the hollow of the sacrum of symphysis pubis, response to amniotomy is poor. The term of pregnancy. The nearer to term, the better is the response to induction and the shorter the latent period. The latent period is invariably considerably prolonged in a majority of cases. If pregnancy is less than 34 weeks, with a well-flexed vertex, the latent period is shorter than when it is deflexed head or breech or face. The site of artificial rupture of the membranes. If the membranes are ruptured below the level of the presenting part, low rupture, the latent period is shorter than when it is ruptured above the presenting part. In inducing the mode of induction, all the above factors are to be considered. Disadvantages. Infection. Intrauterine infection is a common sequelae induction by amniotomy. It is more in cases where there is a prolonged latent period, especially when it is beyond 72 hours. Unnecessary vaginal examinations done by anxious obstetrician do not good but produce intrauterine infection. To prevent this, a prophylactic antibiotic therapy is all amniotomy cases is commenced. Prolapse of the cord. With the artificial rupture of the membranes is done below the presenting part, the presenting part is not engaged or fixed at the brim. Prolapse of the cord is a common occurrence. It is most likely to occur in cases of hydramnios where after rupture the liquor flows out in force and may produce the prolapse of the cord. In case of placenta previa, there is a great incidence of anomalies in the insertion of the cord and hence possibility of prolapsed cord. So, in hydramnios, therefore, it is best to induce labor by high rupture of membranes. It is wise to reduce the length of the latent period, and for this purpose, the oxytocin drip is most suitable and efficient. The procedure of combining artificial rupture of the membranes and induction. The patient is laid down in a lithotomy position and draped. The vaginal examination is done with aseptic precautions. The nature of the cervix is assessed as also the presentation and level of the presenting part, vertex. A finger is introduced into the cervical canal if it is easily possible and the membranes are separated all around the internal os. The speculum is introduced into the vagina, the cervix is held up and the membranes are punctured below the presenting part by a sharp stillet. As much liquor as possible is let out and the small opening in the membranes enlarged by the fingers. The patient is then put to bed and prophylactic antibiotic is started. After artificial rupture of membranes, the fetal head sounds, heart sounds are monitored. If labor pains do not start within 2 hours, an oxytocin drip is started. The drip is also can be started soon after the amniotomy. With this, the success rate is high. Sometimes 2 or 3 drips may be necessary. If fails, the procedure is terminated and proceeded for cesarean section. Buccal oxytocin. Tablets of oxytocin containing 200 units may be given by mouth and repeated till labor is established. Between 1000 and 2000 units may be required, and this renders the method expensive. Furthermore, it is often difficult to control the rate of absorption, and uterine tetany can occur with the threat of fetal anoxia and uterine rupture. Prostaglandins. Prostaglandin is a generic term for a group closely related derivatives of prostanoic acid. It is found in the mammalian tissues, especially the human seminal fluid, and are capable of a wide range of biological activities. Out of 14 natural prostaglandins, prostaglandin E and F, E1, E2 and F2 stimulate the uterine contraction. During pregnancy, when given intravenously, the drug is given as an intravenous drip. Different rates of infusion have been employed, rating from 0.05 micrograms per kg per minute of F2 to 2 to 6 micrograms kg per minute of E1 and E2. Good reports have been reported. The induction delivery interval is successful cases ranging from 2 to 20 hours. Side effects: vomiting, diarrhea, so not beneficial than the oxytocin drip. That's all about the induction of labor at term. And in the next video, I will discuss about some other disease. Thank you.